So we will go ahead and get started. I know some folks will probably join over the next few minutes. Thank you for everyone who's introducing themselves. I'm seeing some intros pop in from Salisbury, from Towson, and I know there are other folks in here. I'm scrolling, but it's great to see folks. We appreciate you joining for another BHIPP resilience break. I will quickly just mention a few housekeeping items and introduce our speaker for today, and then I will turn it over. So if you're interested, keep an eye on the chat for housekeeping items, and Chelsea and Rebecca will work hard to also add resources and links from the talk today. So if you're interested, they will pop in there. Feel free also to add questions or comments. When Kay breaks, we will turn to the chat and open it up for an interactive question and answer session. So we will use questions you add there throughout the talk and certainly open it up at the end. So please feel free to use the chat as things come to mind. And then if you want to find these resources, they'll be available at our website, mdbhip.org, and CME and CEU certificates will be sent out early next week. But if you have questions, feel free to reach out. So I'm really pleased to welcome everyone today. This is one of our BHIPP resilience breaks. We're happy to be together virtually and connect. And we just want to remind you that BHIPP is open and we're happy to take calls and provide assistance. So please feel free to reach out. I won't spend a lot of time on this, but we're open Monday through Friday, 9 to 5, and are offering consultation and support and education to pediatric primary care providers across Maryland. So if you think of questions related to the topic we're talking about today or any other clinical issues related to your patient's behavioral health, please feel free to call us or hop over to the website, and you can certainly link to us there as well. A brief reminder of the services we offer are on the screen. But I'm going to turn it over to Kay momentarily. I'm just going to really quick give you an orientation to who Ms. Connors is and why we're really pleased to have her join us today. So Kay is going to be talking with us today about infant and early childhood mental health, and she's going to orient us to that topic. And we're confident she can do that in 40 minutes, even though this could be a course that we could spend a year or more talking about. But Kay's an instructor at the University of Maryland School of Medicine, and she works in the Department of Psychiatry and is the executive director of the Tagi Mataresi Center for Infant Study and the director of the Center of Excellence for Infant and Early Childhood Mental Health. She's the project director for BNEST, a National Child Traumatic Stress Network Category 3 project, and a Maryland ACE interface trainer. So Kay brings a lot of expertise to us today. Please ask questions and talk about cases. It will be a rich experience for us. Ms. Connors is a clinical social worker. She specializes in child and family traumatic stress and mental health and provides clinical care and supervision in the clinics I previously mentioned, and oversees workforce development projects to improve access to high quality infant, child, adolescent, and young adult mental health services. So we are really delighted to have her joining us today. Kay, I'll turn it over to you.
Thanks so much, Kelly. I'm so excited to be with the BHIPP team and appreciate all my colleagues on that team. And of course, our own team, our infant mental health team. We're a resource to you, and really proud to lead this team of wonderful folks, of which Kelly is a proud alum. So it's nice to be together. And we are funded by the state, the Behavioral Health Administration, similar to BHIPP. We have a Center of Excellence in Mental Health grant, and so we are a resource to you to help with case consultation and training and technical assistance. And we have 2 federal grants as well. So we'll be talking together today about early adversity in childhood and how it impacts young children's mental health and life course. And we'll be talking about some tools and strategies to identify infant mental health concerns or trauma concerns early, and think about some essential components to collaborative care. Pediatricians and pediatric partners in the primary care setting, have the golden ticket, that they're there available at that magical time in early childhood, and you all have an incredible trust with families, and that so we're happy to support you and think about what might work for you all as you play a role in supporting infant mental health, and also working together to try to address early trauma and adversity in childhood. So we know that, there's a lot of guidance about your important role, but we also know that little has been studied, and there aren't a lot of available interventions in early childhood for the primary care setting. So I'm excited that this is on your agenda. And we know that we know this because we know that children even older than 6, as well as children under than 6, have a documented high level of unmet mental health needs. The research community has done an amazing job in helping us connect and further understand the connection between brain health and mental health and physical health. And our colleagues in the early childhood education world were really on this topic early and first, and they understood that early childhood development was essential to school readiness. But what the science really shows us is that early childhood mental health and development is essential to health across the life course. So it is a remarkable opportunity to both partner with our very smart and wise education folks and families to think about how we can use the opportunity during these sensitive slopes or periods of brain development to bring in more resources to families and children and the people that serve them. If you see like the highest peak in these in this remarkable slide by the Council of Early Child Development, you and maybe a child care provider are the folks outside of the family that have the most contact with babies during these periods of time. And by the time they get to school, those peak periods have leveled off and stabilized. So thinking together today about what we might be able to do, how we might be able to use this opportunity, because not only are those sensitive periods wonderful opportunities for growth and development, but on the flip side, they're also sensitive periods where they're very sensitive to risk and adverse situations and circumstances. So early childhood trauma is associated with physical health concerns, including decreased size of the brain cortex that is critical both to learning and IQ and the foundation for behavioral health. And we're still learning, and scientists are still learning about other health significance about stress and the brain. So I know that watching and waiting is a common way of monitoring and monitoring children's wellness, but we might want to start to think together about how we can be more sensitive to these concerns, and also recognize that maybe it's not always best to wait and see. So three definitions I want to spend a little bit of time on, because I think finding the words to speak about difficult topics is part of how we move forward together. So infant and early childhood mental health is really quite a big definition. It really encompasses much more than behavior concerns. As you know, and as you are on the front line of referring children for neurodevelopmental concerns to our infants and toddlers colleagues, and early interventionists and developmental specialists. But we also know that psychiatric conditions can start early in life, including certainly anxieties and PTSD, but also ADHD and mood concerns. There are it also encompasses concerns about psychological development, including learning concerns, and the social emotional foundation of life really starts in these early stages. And even for children that have neurodevelopmental concerns or psychological concerns that can be remediated with therapies, they are in much better shape to make progress with those early interventions if in addition they are also getting the social emotional support that they need. So these things all go hand in hand. And of course, you are frontline in identifying and taking care of children that have all kinds of intrauterine exposure, including substance exposure. So it's our job together, and kind of under BHIPP's leadership, is to try to put in place screening, assessment, brief interventions, referral, and care coordination for children with these concerns. So making these connections across discipline and across communities is essential to children's mental health. And this is my favorite definition of early childhood mental health from Alicia Lieberman and Patricia Van Horn. And I think it's a really manageable way to talk with families about what's often a stigmatizing topic, which is mental health. If we can normalize discussions about mental health, we can go a long way in starting to reduce the stigma that is often associated with mental health concerns. So talking to parents about helping their children grow well and love well, you are the experts in doing that. And you are the trusted person besides maybe grandma and granddad that parents turn to. So what we're looking for when we're assessing whether children are growing well and loving well is, are they able to experience and tolerate and express a range of emotions without lasting collapse? So you know better than anyone that all kids have temper tantrums, and actually they need to have temper tantrums. It's a part of normal development. It's a part of how they express themselves and then get support to regulate particularly challenging or difficult emotions. But even exciting emotions can become overwhelming to little kids, and that often results in what we call being too silly. So that whole regulatory process happens in the context of trusting and intimate relationships with parents and other family members and caregivers. And this is where you provide so much support to the parent. The support that you give to parents fills up their cup, so they're able to get more confidence and be able to support their child's development. So that trusting relationships are nested in both in families, but in the relationships providers have with families as well. And how we know things are on track, particularly for this youngest crew, is school readiness. So that's a culturally valued skill that we in Maryland families are really aiming towards helping get their kids school ready. But that includes also social development, being able to make friends, being able to have positive relationships also with other adults, teachers as they grow older. And in each community, there might be other culturally important skills that parents want their children to be able to attain, and activities they want them to engage in. And because you not only treat children and families, you also are very, you know your communities well. So you will know other cultural values of the families that you serve. So that it sets the stage and the importance for screening for social emotional problems. And although pediatricians, I believe in some of the BHIPP reports even do quite a good job with screening, there still is some uncertainty about doing it in the youngest years, so at birth through 3. So thinking together about what we know about behavioral health concerns, that actually children ages 2 to 5 have the same rate of diagnosable behavior concerns as older children. So about up to 20% of children have behavioral and emotional disorders. So the period between age 2 and 4 are critical periods for symptoms to emerge, but also incredible opportunities for early intervention. And particularly paying attention to stress and trauma and anxiety and early signs of ADHD. These are hard conversations really to have with families and sometimes even within our own team, particularly as it relates to infants. I'm just going to read this, I think, very poignant quote from Charlie Zena and Mike Scaringa from Tulane. There's something deeply disturbing about the juxtaposition of violence and infancy. Infancy is a period of development that we associate with innocence, with hope, and with the promise of the future. And so being able to hold both the capacity and for hope and growth, and also turn an eye to and be direct about exposure to violence is really quite a challenging and sometimes feels like a daunting task. You have to overcome really centuries of myths that children are too young to be impacted by violence, and myths that children will bounce back from adversity. And in fact, children are resilient, and that is the good news, but they're not resilient on their own. They're resilient in the context of relationships and support, and they need to be safe, fundamentally safe, to be able to be resilient. So that gets us to the third definition, which is how do we talk about trauma? And you've probably heard this wonderful paradigm shift that SAMHSA has been leading the country to shift from talking about what happened to someone rather than what is wrong. So moving from an understanding that people's life experience has a great impact on their health, and moving away from a more deficit way of speaking about health concerns and behavioral health concerns that people are experiencing. So SAMHSA has recommended that we think and talk about trauma as the 3 E's. So traumas are an event, so that's the first part of the definition, and it's the first part of the diagnosis of traumatic stress. Or it could be a series of events or a set of circumstances that is experienced by an individual as physically, emotionally harmful or life-threatening. And for young children, that can include an event that happens to themselves or an event that happens to the people that are there to protect them. And these events and the experience of these events can have effects on how the individual is functioning and their mental, physical, social, emotional, and spiritual well-being. So it is a rather all-encompassing way of thinking about trauma. And by being able to speak about the 3 E's, it gives us a stepping stone to talk with families about what happened to them and how they and their young child might have experienced those events and what effects that might be having. And that really is the nutshell of what the screening is that we'll talk about in a little bit. So in early childhood, we have to go a little bit deeper to understand the definition of trauma, because young children develop in the context of relationships. So a young child is not on their own. That what happens to them or what happens to their family is uniquely intertwined. And so for young children, thinking about these experiences, this exceptional experience that is powerful and dangerous and overwhelming to the child's developmental and regulatory capacities. Thinking back to those sensitive stages and periods of development, those periods are great periods of capacity building and opportunity, but again, they are fragile and need protection to fully unfold. So the stress response is activated in their brain and in their nervous system, and there is associated with these scary, frightful events is there's a loss of the caregiver as the protective shield. And that really is intertwined with how we think of the importance of attachment. Attachment is first and foremost a protective shield to make sure that the young child survives. And then there's a loss of security or trust. And so learning to, if the events were caused by other people, learning to gain trust again in other people, or losing the secure feeling that they might have had in a certain environment. So the other thing that research has told us is that not only is it important to know what happened, but it is important to know when these things happened. So if they happened in early childhood, the impact on their social emotional well-being and brain development is very significant. Also, this chart, and I'll drill it down in a minute, shows us that young children and older children are at risk of different kinds of traumatic events. So this is a database from the National Child Traumatic Stress Network. So these are all children coming for trauma services. So it's not a general population. So we're drilling down, trying to, in this data set, looking at what kinds of traumas do children of all ages come in to get treatment. And what you can see on the early childhood side is that it really maps on to what we know as from the adverse childhood experience study. That living with parents that have untreated mental health or substance abuse or substance use disorders was the highest number of children coming in for those early childhood trauma care. Neglect, and that's what we know from the child welfare data, is the most common form of child maltreatment. And then domestic violence, and then the other emotional and physical abuse as well. So unfortunately, these numbers have been consistent in the child welfare data, and I'm afraid we might see a spike as we emerge from COVID. But young children are the most vulnerable to maltreatment. About 1/4 of maltreated children were under the age of 3. And the highest rates of victimization were younger than 1, which is getting back to the wisdom of what Zena and Skoringa said is quite hard to hold in mind. But that's why we have to, bear witness to these numbers. Domestic violence is the most common form of family violence, and 1 in 9 children in a national survey reported any exposure to domestic violence. And unfortunately, if violence is a strategy that is present in a family between adults, there is a greater risk and likelihood that violence and aggression is also used against children. We know from our work here in Baltimore City and other colleagues across the country, including Sandra Graham Berman and Betsy Grove in Boston. They've been studying the impact of community violence on young children. And thinking about our Head Start kids, Sandra found that Head Start children were disproportionately exposed to community violence, ranging to 77 to 93% of 3, 4, and 5-year-olds had been exposed to significant community violence. The other area that you all have an amazing opportunity to think about both screening and providing brief intervention. It relates to medical trauma. So we know that young children, the other common trauma for young children is injury. And that's why, you coach families to do such a good job and all the kinds of safety and home protection systems that they can put into place. But young children are more at risk of animal bites and other physical injuries. And when we think about even life-saving medical intervention, we have to hold in mind how frightening that is for young children. It's another opportunity to think, like, as adults, we think, oh boy, our child has gotten the best care because this very frightening illness or injury has been treated. Providers can feel good about that too. But sometimes young children are still left with the scary and terrifying feelings and memories associated with those intrusive but life-saving interventions. So I wonder, Kelly, if it would be okay if people put in the chat what they see as we move into kind of how to recognize symptoms of child traumatic stress, if they might either, whatever you want, open it up or put it in the chat.
Either is fine. We have just almost 70 people on, so
okay.
The chat might be more manageable than just full-on audio. So do you mind just giving that direction one more time, Kay, so folks are really clear, and then I can help you monitor the chat, or you're welcome, whatever's easiest.
Okay. So I just would like to invite people to put in the chat what you might see young children expressing, either as it relates to what we would call intrusive symptoms, and we'll drill this down a little more as we talk, avoidant symptoms or negative changes in the way they're thinking or acting or expressing their feelings, or increased arousal.
Okay, is it helpful if I let you know what I see coming in?
Sure.
I see someone added they become quick to anger, displaying inappropriate behavior, like not appropriate for their age. I see another anger, hitting and biting. Shutting down, sleep changes, that they might be withdrawn. A setback with toilet training, hypervigilance, regulation issues, increased separation issues, regressive behaviors, displaying, quote, babyfied behaviors. Sorry, jealousy of siblings or other kids who might get, in quotes, more attention from caregivers. And that's the end of the list for now, but I can certainly let you know if we have more come in.
Yeah, it's a brilliant list, and it really maps on exactly to what the literature says. So you are really experts in identifying these common trauma reactions: clinginess, separation fears, eating and sleeping disturbances, physical aches and pains. It is also common not just for young kids, but older kids as well. Crying and irritability, appearing frozen or more or moving aimlessly, persevative or ritualistic play, where play is usually one of those things that we use to to master thoughts and feelings and understanding, but when you see kids kind of stuck in a play pattern, fearful, avoidance, phobic reaction. So it can be just an overall fearfulness or new specific fears to things that they weren't afraid of before. Magical thinking related to the trauma, including for our 3, 4, and 5-year-olds, often that somehow it's their fault, whatever happened, or that they just weren't good enough, or they had done something bad. Nightmares and triggered responses to reminders. So, you know, that I think it's just you've just kind of shown that primary care is a great place to identify the signs and symptoms of traumatic stress. The other things that you were very tuned into were those regressions in developmental skills. Totally is one of the more common ones, as well as language. And the kind of intense separation anxiety is normal during this phase of development, but often the intensity of it is much greater, as well as like new onset of aggressive or behavior. And as it relates to children that have had kind of medical traumas, whether related to illness or injury, our colleagues at CHOP in Philadelphia report that these kids have unwanted or intrusive thoughts about what's happened. They strongly avoid things that are reminders, which could certainly make your office visits challenging at times. And they are at risk of the other reactions that you all talked about. The National Child Traumatic Stress Network, now we're going to kind of get into the resources and strategy part of the conversation. Right here is the direct link to a wonderful handout that separates out, you know, what to look for in children 0 to 2 and what to look for in children 3 to 6. So Betsy Groves and other experts across the country developed this really helpful guidance. And there are other tools and resources, including webinars that you can get CEUs at the National Child Traumatic Stress Network. So if you want to spend some more time on their web and dig into their resources, I invite you to do so. But in general, what we know, and really the kind of how the network was founded, was on some of the research that Bob Heinus did about understanding trauma in the developmental context. So understanding that trauma derails children's development, in essence. They have to spend so much energy and time dealing with and coping with the overwhelming feelings and reminders, and they don't yet have the internal capacities to come to terms with what's happened. And this puts them at risk of not having the reserve to explore the environment and to stay on task and master the developmental tasks of their stage of development. And that is one of the reasons, you know, that traumatic stress, if it goes untreated, can have these long-term impacts. The other research, and I mentioned it, is one of the partners is at CHOP, and they have, I think, a really helpful a toolkit for you all, and also I think a helpful framework for pediatrics. So they call it the Pediatric Psychosocial Prevention Health Model. I'm sure you're very familiar with various pyramid models. So thinking, you know, kind of at the universal level, that when traumas happen, and in particular medical traumas, children and families are distressed, but they're resilient. You know, they might be able to say, this was very scary, but, you know, by getting the help they needed, you know, also their distress goes down. So the general support that you all give is kind of that foundation place to start from. But also including in that screening for indicators of high risk. So maybe for children that have mental health concerns, or are using your integrated care or collaborative care support partner, wanting them to get extra help and resources as it relates to trauma could be important for this phase. And so when children are screened or are referred, providing interventions or services, including care coordination, to help reduce the stress, but also to monitor the distress. It's, we expect to see distress for about a month, but after that, then we're moving into a mental health concern that might be diagnosable. And at the top, so that takes us to the top of the pyramid, where a consult to behavioral health is really warranted. So a way to think about, mapping, just borrowing from your ABC model of thinking about the vital signs of physical health, thinking about a trauma responsive ABC, we could think about awareness. So appreciate all of you joining today to think about this together. And also in your role, looking for and asking about bodily responses, startle responses, fear responses, all the things that you already said, regressions in development, sleep and eating changes as it relates to tracking what's how's the child reacting and responding to what's happened, and connections to parents and caregivers and providers and resources. So the thing that research has shown about recovery is that it's all done in the context of relationships. And so for this stage, attachment and connection to resources for families is the healing, the secret sauce for healing. And then to break down a little bit further into brief interventions, our colleagues at CHOP talk about the DEF approach. So after the ABC, you can think about DEF. So ask about fears and worries, or to monitor distress. Consider that grief and loss might be an issue that often is associated with traumatic events. And of course, asking about pain. So much of trauma responses are held within the body, and learning to ask about that is really important. And then emotional support, so connecting patients and parents to needed supports and mobilizing existing supports. And all of this in the context of family, including making sure that maybe you only have the one parent in front of you, talking about the breadth of family resources that might be available. And if there isn't, building in other resources. So so now we'll just talk briefly about identification strategies, and for those that can go deeper into assessment and diagnosis and intervention. So that's the other component of an effective trauma-informed approach. So in routine care, without going into all the details of what happened, but sticking to some of those thoughts from the SAMHSA guidance, is a simple screening for traumatic events is asking, what's the most upsetting thing, or has any upsetting thing happened to you and your child, either if you're meeting them for the first time or since we last met, so that we're specifically asking about frightening and overwhelming events and putting that into our conversation. And then the psychoeducation part is, after upsetting events, children can sometimes change the way they act or feel. And then you can go down a little bit deeper to ask, then can you tell me whether your child has experienced any of these behavior change since the upsetting event, and has it lasted more than 1 month? And that's really a way to kind of use the CHOPS pyramid model. I know sometimes people are sensitive around getting too far into some of the traumas, but the goal here is to help parents reflect on that young children can be scared, and that can have an effect on them, and they can look out for what to look for, and you can connect them to help if needed. There are evidence-based screening and assessment tools that are available. The one developed by Mike Scaringa is in public domain at Tulane University website, and there is a specific trauma event screening instrument that's usually used by mental health providers, and there is being tested a new screening and assessment tool that maps onto the DSM-5. I'm happy to talk with anybody that offline or in an email about some of these tools. So when the DSM-5 was revamped, they wisely took trauma and PTSD out of being kind of built into the anxiety categories and really built out its own specific category. And I think this really reflects well what we see in the treatment and diagnosis of trauma disorders. So PTSD, adjustment, and other attachment and social disengagement disorders. So the diagnosis is, so when you're referring to primary care folks, what you're looking for from us is that we are specifically asking about what has happened, because not only the type of trauma is important to know, but when and how often it happened is also really important to know. And that's the first part of the diagnostic process. And then we're looking for various symptoms, as you already well described, and the duration. So is it an adjustment or a short-lived reaction, or are these symptoms continuing? And as we already discussed, that's significant for children's development. There is, I just want to make you aware that there is a more age-appropriate diagnostic classification system that we are working with partners around the country to advocate for being more widely available, because I know, and rightly so, there are some criticisms of using the DSM-5 for this population, though I do have to say that DSM-5 under Mike Scaringa and Charlie Zinni's leadership does have an early childhood adaptation for PTSD. So thinking about brief interventions, and we really want to think about it from a two-generational approach. What's going to help the child, what's going to help the parent, and what's going to help the parent-child relationship? That's really the target. Those are the three targets of a two-generational approach. So we want to be able to help parents understand that young children do have fears and learn to recognize their fears. Young children have fear of pain. One of their most significant fears is of loss. We see that as it comes out in separation anxieties, and fear of losing love and approval. So that really is about that attachment system. But they also have fears of things happening to their body, particularly as they get older and can move around in the environment. And as they move into being a preschooler, they have fears of being unlovable or being bad or people not liking them. So how we respond to children, and if they're responding from a fear-based perspective, these are the first fears that we try to think about with parents. On the website, Kelly and the team are putting up this tool that our team and folks in the National Child Traumatic Stress Network helped to create. And one of the hardest things is to know what to say in these difficult and stressful discussions. And so this is a nice guidance for parents, but also child care providers that says when when it says from a kid's perspective, when I act this way, I want you to know that I might try to get your attention because I'm scared and worried that something might happen to us, as opposed to kind of just labeling kids as attention seeking, but trying to get to the root or the meaning of children's behavior. And then this is how you can help. Spend a little more time with me. Remember that I'm not trying to bother you or make you mad. So these are some of the things that we try to talk about in therapy, but also these are tools for parents and providers as well. So I think we really already talked about that. And I want to just spend a little time talking with you about a model that we're really excited about. We have 2 Healthy Steps sites here in Baltimore, and our National Child Traumatic Stress Network grant is helped us to grow, to build a second site here at University of Maryland. And the work of the national group that has developed and researched this study, thanks to actually our colleagues at Johns Hopkins, really saw the wisdom in, that primary care is a really important setting and portal to address the developmental and family needs of young children, because families have access to primary care providers. You, as we already talked about, are a very trusted group of providers, where often mental health is, more of a stigmatized or concerning provider group, unfortunately. And that you offer a non-stigmatizing setting, and that you see parents very often, 7 well child visits in the first year of life. So it's an amazing opportunity. I'll just tell you a few more things about it and then we can pause. So you embed a Healthy Steps specialist into the primary practice, and they help with supporting social, emotional, and behavioral screenings, making it routine, but also being there, being available, similar to your integrated approach. So when there is a finding, that there's someone to be able to provide brief intervention or connect with longer-term care. A child development support line that parents can call with the, they develop a trusting relationship with the Healthy Steps specialist, but also being providing in the moment, on the fly consults for the primary care team, and then helping with an array of care coordination and parenting programs, including being able to provide groups and other things. So I think, Cal, I'll stop here, but people can, I'll just say what the outcomes are. So the outcomes are as studied by Johns Hopkins originally, and the work is continuing with a very large grant across the country, that families that got the Healthy Steps, the benefit of the Healthy Steps services, had increases in parenting knowledge and practice. There's parent and physician satisfaction, improvements in maternal depression and through the early screening, and we've replicated that finding in Baltimore. Supports for early literacy and school readiness, improvements in child safety, and connections to needed resources, including things related to food and child development. Cal, I'm going to turn to you if I should go more into mental health interventions or take the time to talk with the group.
Well, thank you, Kay. Maybe I will open it up and ask folks to start adding questions about kids maybe in their practice, or questions of what you've covered. I don't see any popping in yet, so maybe if you want to take another minute or two, and we'll let the questions come in, and
Okay.
that way we would have nearly 10 minutes for questions, maybe 9. But I'll monitor what's coming in. So if you want to take another minute or two, hopefully that'll be the best of both worlds. I will tell you, I do see a question coming in about the workflow if a practice is interested in healthy steps. So
okay,
they're starting to come.
Okay, good. So, so when children do need and families do need more intensive mental health treatment, I just want to make you aware of child-parent psychotherapy. This is a model developed by Alicia Lieberman and Patricia Van Horn and Chandra Ghosh Ippen. There's their website. And they also have robust findings about improvements in reducing children's PTSD symptoms, increasing children's IQ, decreasing cortisol levels, and improving parent-child interactions, including more secure attachments. And also going back to that idea of a two-generational approach, parents also had improvements in their own PTSD and depression. So this is a robust model that we are very committed to helping to bring to provider groups in Maryland. And so in closing, you know, another simple way to kind of talk about and hold in mind why it's important to talk about this is that what children need is to feel loved and protected, understood, and to be able to know their feelings and to feel capable. And that's really, you know, the goal of our infant mental health prevention and intervention models. And it's a privilege to be able to talk to you. And I'll give you two quotes from remarkable leaders in this area. Alicia Miller's quote, "The truth of childhood is stored in our bodies." I think that's what we've learned through the ACE study. And someday, oops, forgot the D, someday our body will present the bill. And Alicia Lieberman has called us to try to speak in one voice on behalf of traumatized children. And so be happy to take some questions about how to collaborate to speak in one voice in primary care.
So I will, the first question, as I mentioned, Kay, is Dr. Fulton is asking if you could talk a little bit about the workflow in a pediatric practice, if they might be interested in healthy steps.
Yes. So the model is called a collaborative care model where, and this is obviously a little more challenging during COVID because we can't have too many people in, you know, because of social distancing. But the ideal is to have the healthy step specialist be part of the exam. So either the beginning or end, or if they're able to, the whole time. That's a way for the healthy step specialist to get to know as many people in the practices, families in the practice as possible. But also in very big practices, like I know today our practice has 30 well visits. So, you know, that Ashley cannot get to all of them, but so the primary care provider can prioritize. So we often use Epic, you know, both to see who's on the schedule, to monitor for ourselves, but also using notes, you know, to so that she can know what's the priority of the physician team. And then, of course, you know, she has a child development line, so parents call, they like to text mostly, and so she can easily respond to them at different times. And we have used teleservices too for follow-up.
Thanks, Kay. You have a question from Miss Moorish. I know, another CIS alum. Can you recommend an online course for schools to better understand what to do when a child is displaying some of the behaviors discussed?
Hi, Ms. Morris. Yes, I think the online courses at the National Child Traumatic Stress Network, which are all free, they have specific school-based ones, and they have a whole early childhood series as well. And you'll hear another alum talk on that one, which is Jessica Latora.
And a follow-up from Dr. Fulton. Do you use ACEs screenings along with healthy steps?
This is a very good question, and this is part of what our grant is looking into. So thank you for that question. So as you know, the ACEs was not developed as a clinical tool, it was developed as a research tool. And so now as providers, both primary care and mental health folks, we're trying to sort out what is the appropriate pathway for assessing for traumatic events. And so we are going to be working with the University of California, San Francisco to pilot test some more family-friendly trauma screens, both related to events and related to reactions. Kelly, I can also send a really good paper about kind of what's the dilemma for the field to think about on this.
That would be great. And Dr. Fulton just asked Pearls about the Pearls with a question.
Yeah, so the Pearls is the California Dr. Nadine Burke Harris. And so what's really nice about the Pearls, and we are going to pilot that one, is that the family doesn't have to tell you which events, but just how many happened. And so that gets to the aspect of the ACE study that says that it's about a dose response effect. You know, so the idea, and we have done this in Healthy Steps too. Another way is that you do the ACE screener with parents, because the ACE screener really is an adult, you know, looking back in your childhood. So if the parent has ACEs, then you're able to say, you're a 4, let's try to make your kid be a 1 or a 0, you know. So it's another way to kind of approach it.
That would be great to learn more about that, Kay, and as you're moving that forward with our co-located interns through BHIPP, and I think some folks are on the line that are involved, either primary care providers or leadership from that team. That is what we train them on in the summer, is the Pearls, and not asking about specific events, but just about exposure. So it would be exciting to learn more as you move forward with that grant, so that we're really our interns and providers understand best practices in that area.
Yes.
So I don't see any other specific questions, but let me check the Q&A, because I was in the chat and sometimes things also come in the Q&A, and I want to be sure I didn't miss anything here. So there are a couple, it looks like here, just about logistics, and I think Rebecca and Chelsea have added that the materials will be available on our website early next week. So I think we've gotten to all the questions. If there's any last minute questions, please feel free to add them in. And I know we're down to our last minute or two.
And I'll send you some resources related to the questions that came up.
Excellent. I will pop into just back from the Q&A to the chat to be sure we didn't miss anything. But I think we caught it all. Thank you.
Thank you, Kelly. Thank you, everyone.
Yeah, thank you for joining us. This was wonderful. Have a great afternoon. Kay, thank you again.
Take care, everyone.
Bye-bye.